Our next speaker will be Dr. Oren Fix. So Dr. Fix, you can go ahead and start getting ready to share your screen. I had the pleasure of being able to present Dr. Fix. So Dr. Fix went to residency and GI fellowship at Boston University Medical Center, followed by transplant hepatology fellowship at UCSF. He has since been primarily working at the Swedish Medical Center in Seattle while dually appointed as clinical associate professor at University of Washington. He has written over 50 papers and has given multiple lectures both domestically and internationally. Relevant to this lecture, last year he was appointed as co-chair of Clinical Oversight Subcommittee for the COVID-19 Task Force for the AASLD and the chair of the Abstract Review Committee for AGA, focusing on COVID-19 impact on training. Dr. Fix, thank you so much for coming to talk to us.
Well, thank you so much for having me. I really appreciate the invitation. I'm going to be focusing on immunosuppression, but I'm going to cover a little, some of the studies that you just heard from Renu in a different context. So you'll get a double dose of some of those big studies that you've heard. And this is my outline. I'm going to talk first about the COVID-19 timeline in the U.S. And the AASLD's response to COVID-19. Which is how I've become involved in addressing COVID-19 aside from my clinical practice. I'll talk about autoimmune hepatitis and then transplant recipients, and I'll end with just a brief bit about the COVID-19 vaccines in liver disease. So the timeline in the US, as you all know by now, the first case of COVID-19 in the US was on January 20th. It was here in the Seattle area where I'm practicing. And the first death in the US was very soon after that in February, also in the Seattle area. So you can imagine, as someone practicing in the Seattle area, I was pretty frightened about what was coming and trying to figure out how we were going to manage our liver transplant program and our transplant clinic, as well as our general hepatology clinic. On March 11th, the WHO declared COVID-19 a pandemic. And at this time, everybody in the United States was watching Italy very closely. This was the epicenter after China. And you could see here that on March 11th, there were 12,000 cases in Italy, which seemed like a lot back then. Now we have over 23 million cases just in the US. So that was nothing really, and we didn't know what we were heading for at the time. But there was a lot of predictions at the time that the United States was just behind Italy by a few weeks. And we were hearing stories from Italy about healthcare workers getting infected, about ICUs being at capacity, about having to ration care. And so this was a pretty frightening time for all of us, and particularly those of us in Seattle, because we fully expected to be hit the hardest in the beginning. On March 23rd, the AASLD, or just before March 23rd, the AASLD decided that our society needed to have a response to this to help liver providers manage this in the best way that we could. We recognized at this time that there wasn't much data, that we were going to be basically presenting expert opinions. So we put together a working group. Bilal was part of that working group. Very quickly, we had some guidelines up online on March 23rd. That's since been updated many times and downloaded over 8,000 times and translated into other languages. A few days later, we presented our first webinar to go over that document, and we've since had 16 webinars. Julius, one of our first speakers tonight, actually presented about some of the disparities in COVID-19 at one of our webinars. Our webinars have been viewed over 379,000 times in total. So we're reaching a large audience, which is exciting. And then we finally published a paper in hepatology, which was based on our online guidelines. That's been cited over 114 times. So this was AASLD's original response, forming this task force that's done mostly this work that you're seeing here, but a lot of other work as well. And everything related to COVID is found on this website here, asld.org/COVID-19. I encourage you to go there to download our latest update of the guidelines, as well as be able to watch recordings of our webinars. So moving on to the meat of what I was asked to talk about, which is COVID-19 and immunosuppression. So at the beginning of the pandemic, we speculated that the immune response was the main driver for pulmonary injury attributable to COVID-19. And we knew from SARS and MERS that patients that were transplanted didn't do so badly, that maybe post-transplant immunosuppression wasn't a risk factor for mortality in those viruses. And we speculated it might be also true for SARS-CoV-2. and that maybe immunosuppression is protective. Since then, we've had a lot of studies that show a mortality benefit with the use of corticosteroids for the treatment of critically ill patients with COVID-19. As you know, the recommendation now for using dexamethasone from the NIH and the Infectious Disease Society of America for hospitalized patients with COVID-19 that are on mechanical ventilation or supplemental oxygen. That's a pretty common treatment right now. So hard to imagine that if that's treatment of severe COVID-19, that a patient who's already on immunosuppression is necessarily at higher risk, although the CDC has identified patients who are immunosuppressed as being at higher risk for severe COVID-19. One of the earlier studies, a really small study of 10 patients from Italy with autoimmune hepatitis who were on immunosuppression and had COVID-19. 4 of them had cirrhosis and 1 decompensated. And you've already heard that decompensation is a strong risk factor for death of COVID-19. That was the only patient in this study that died. 2 were on high-dose corticosteroids for the treatment of acute onset of autoimmune hepatitis, and these are the only 2 patients who had high ALT and AST in the study. 6 were hospitalized, 5 had pneumonia, and 3 required non-invasive ventilation. But the liver biochemistries were normal in all of these hospitalized patients, except for those 2 who were being treated for acute autoimmune hepatitis, and actually those liver enzymes improved over time. So the authors compared this to other patients with COVID-19 and suspected that or speculated that the course of COVID-19 in autoimmune hepatitis may be similar to that of non-immunosuppressed patients. They also warned that preemptive reduction in immunosuppression during COVID-19 could be potentially harmful. And indeed, now NIH treatment guidelines for COVID-19 recommend that anybody who's on oral corticosteroid therapy prior to a COVID-19 diagnosis for an underlying condition should not discontinue their corticosteroids. So this applies to autoimmune hepatitis, it applies to IBD, et cetera. And the corollary to that is if you've got a patient with or without COVID-19 during this pandemic who develops a strong indication for corticosteroid treatment, for example, a flare of autoimmune hepatitis, then you should initiate immunosuppressive therapy. You shouldn't hold back because of the risk of exacerbating COVID-19 or developing COVID-19. There's been a couple questions about liver transplantation, and this was also a pretty frightening time in the beginning of the pandemic, wondering what's going to happen to our liver transplant patients with ORs essentially closing for elective cases, many ORs being turned into ICUs, and ICUs and ventilators being reserved for future COVID-19 patients. There was a lot of concern that liver transplantation would come to a halt in the United States and across the world. And actually, some countries actually did put a hold on or a pause on liver transplantation. The United States did not. You can see in these graphs that living donor liver transplants did take a dip in around March and is not really caught up to 2019 levels. But overall, liver transplants in the United States have maintained the same volume as 2019. And that's because of the early recognition that liver transplantation is not an elective procedure. It should not be postponed. And there's no reason to make this pandemic worse by putting our patients who are at urgent need for liver transplantation at risk, even if they don't have COVID-19. So I personally don't have data on how alcoholic liver disease patients have fared specifically with rates of transplant. I think that would be interesting to look at, and I'm sure the data is easily available. So moving on then to how liver transplant patients have done in COVID-19. There was an earlier report from Lombardy, Italy, again, one of the early epicenters of the pandemic, that described 6 liver transplant patients from their program, 3 who were long-term liver transplant recipients who all died of COVID-19 from pneumonia or ARDS, and 3 who were really recently transplanted just in the last 2 years, who all had mild COVID-19 and did not require hospitalization. The 3 who died all were over 65 years old, had hypertension, obesity, diabetes, and hyperlipidemia. So the authors wondered, the patients who died, did they die because their immunosuppression was relatively lower than the patients who had been recently transplanted? Or was it more likely related to their comorbidities? And I think with more data coming out about transplant recipients, not just liver, but other organs, I think it really comes down to the comorbidities, and that's why some of these patients are not doing well. One of the earliest reports from New York City on transplant recipients was this paper about 90 solid organ transplant recipients with COVID-19. Some were inpatient, some outpatient. The study included 13 liver transplant recipients, 9 with mild or moderate disease and 4 with severe disease. And this was largely an observational study. They showed that immunosuppressive medications were reduced in most hospitalized patients. Usually it was the anti-metabolite that was decreased, so mycophenolate generally, but also in some cases steroids and calcineurin inhibitors were decreased or held. 34% of these patients required ICU admission, 35% were mechanically ventilated. I guess one patient was mechanically ventilated outside the ICU. 24% died, which was half of all ICU patients, and 54% have been discharged at the time of publication. And there was no reported acute cellular rejection. Again, this was an observational study, really no big guidance as far as how to manage patients, but it was interesting to see that a lot of patients who were hospitalized had their immunosuppression reduced. And then this study you've already heard from Renu, the COLD consortium, which is more recent, but had a similar finding as far as immunosuppression. So 112 liver transplant recipients from 15 US medical centers, median time from transplant of 4 years. And here immunosuppression was changed in half the patients during their COVID-19 illness, more often in those with severe disease, which was defined as patients requiring ICU admission, vasopressors, or mechanical ventilation. The most common change was holding mycophenolate, followed by a decrease in tacrolimus dose or holding tacrolimus. One patient had acute cellular rejection after reducing tacrolimus, and the reduction in immunosuppression was not associated with liver injury or mortality. And the incidence of liver injury and the risk factors was the focus of this study. So again, this is mainly observational. There was no guidelines as far as what to do with immunosuppression. It was interesting to see that early in the pandemic and also a little later on that people are reducing immunosuppression in patients who are hospitalized with COVID-19, and whether that's contributing to improved outcomes in these transplant patients or not is unclear. I think the message of this study was it's safe, probably safe to reduce immunosuppression a little bit and not risk rejection, but that's of course the big concern. Managing rejection in a patient with COVID-19 is really very difficult, so we want to avoid that. So this mirrors what we recommended in our guidance document from AASLD, and these recommendations haven't changed all that much since the beginning, but now data is sort of starting to support it a little bit better. So in post-transplant patients without COVID-19, we recommend that you don't make anticipatory adjustments to the current immunosuppressive drugs or dosages. So that also mirrors the later NIH recommendations. But in post-transplant patients with COVID-19, it's reasonable to consider lowering the overall level of immunosuppression, not because we have data to say that that's the right thing to do, but mainly because we're dealing with a very severe infectious disease, potentially lethal infectious disease. And this is how we manage infections in patients who are immunosuppressed in general. It's reasonable to target the anti-metabolite, azathioprine or mycophenolate, as the first drug to lower. And that's mainly related to it contributing to lymphopenia, which is also already a problem in patients with severe COVID-19. But it also may be reasonable to reduce tacrolimus depending on things like risk of kidney injury. We know that that's a problem in COVID-19. And it's really important that you monitor the tacrolimus and cyclosporin levels in these patients. But bottom line, adjusting immunosuppression has to be individualized. It really is based on the COVID-19 severity and also the risk of graft rejection. If this is a patient very recently transplanted, you probably don't want to be messing around too much with their immunosuppression unless they're severely ill from COVID-19. And now we're starting to get more specific information about immunosuppression. So this is a study that was also mentioned by Renu of 111 liver transplant recipients in Spain with COVID-19. And this study showed an increased risk of acquiring SARS-CoV-2, almost double the rate in the age and gender matched population, but a lower mortality rate than the matched general population. And this study also showed that baseline immunosuppression containing mycophenolate, especially high doses over 1,000 milligrams a day, was an independent predictor of severe COVID-19. So this supports the recommendation that perhaps in patients with severe COVID-19, we should be reducing the mycophenolate. And then you've already heard about this secure cirrhosis and COVID-HEP international registries. They've published papers on chronic liver disease, which you heard from Renu, and also a separate paper on liver transplant recipients, in which they described 151 of them with COVID-19. 124 of them were hospitalized, 31% required intensive care, 19% died. And here they showed that liver transplant status didn't significantly increase the risk of death in those patients with COVID-19 in a propensity score matched analysis. And that their conclusion was that liver transplant recipients are probably not at increased risk of severe COVID-19. And this is one of the newest studies that I've read specifically about immunosuppression in COVID-19. This was a large European registry of 243 liver transplant recipients with COVID-19. And in a multivariable analysis, they showed that tacrolimus was associated with decreased mortality compared to other immunosuppressive agents. They also showed age, diabetes, and chronic kidney disease as independent risk factors for death from COVID-19. That's not new information. And an accompanying editorial wondered if the protective mechanism of tacrolimus was because it was immunosuppressive or whether it's potentially a direct antiviral for COVID-19. There's actually a study from 2012 looking at coronaviruses in general, particularly SARS, the first one, showing in vitro an antiviral effect for tacrolimus. So, really, and before I move on to the next thing, immunosuppression is not all the same. And so, yes, we're recommending that overall you should consider reducing immunosuppression in patients with who are hospitalized with COVID-19. But perhaps you should target the anti-metabolite mycophenolate first and leave the tacrolimus alone, unless, of course, they have a kidney injury, in which case you might have to reduce the tacrolimus. So now I want to move on to COVID-19 vaccines and liver disease, because I think this is certainly related to immunosuppression as a general topic, and also because this is really what's on everybody's mind right now. So as you know, there are two vaccines that are both mRNA vaccines that have emergency use authorization from the FDA, and both companies included patients with chronic liver disease in their clinical trials, but they were stable chronic liver disease, very few patients with severe disease, and we don't really have a lot of information about how that was defined. Both studies or both companies excluded patients who either had immunosuppression therapy or had an immunosuppressive condition. So we really have no data on post-transplant patients or autoimmune hepatitis patients who are on treatment and how they do with the vaccines. Overall, there were very few liver patients in each of the clinical trials. So 214 patients in the Pfizer studies, 196 in the Moderna studies. That was both of them happened to be 0.6% of the total participants. And in Pfizer, 124 got vaccine, 90 placebo, and they didn't report on the vaccine efficacy for the liver patients specifically, but those who had comorbidities, which included liver disease, had a vaccine efficacy of 95%, which is about the same as the overall population. And in Moderna, 100 patients got 100 patients got vaccine, 96 placebo. Surprisingly, no patients with liver disease got COVID-19, probably just lucky. But because of that, we really can't determine the viral vaccine efficacy for the Moderna vaccine. So, we're starting to get into phase 1C. I know this is a moving target, and recently the CDC recommended vaccinating everybody under 65. But at least originally, phase 1C included those with underlying medical conditions, which includes liver disease, includes immunosuppressed patients. And of course, all of us are getting questions from our patients about when are they going to get the vaccine, should they take it. In fact, I just had a patient who told me that she was offered the vaccine. She's up in Alaska, and it's being offered to the general population there. She was offered the vaccine and decided not to get it because she's hearing about all these mutations and assumed that the vaccines are not going to be effective against new mutations. So there's a lot of myths out there that we have to dispel. But it's reasonable to think that transplant recipients may have lower antibody responses and waning titers compared to those without transplants. That's what we've seen in hepatitis B vaccination, for example, and other vaccines. Patients who are vaccinated pre-transplant may have reduced protection post-transplant, especially if B-cell depleting therapies are used. So it's possible that vaccine efficacy is going to be lower in our immunosuppressed patients and our post-transplant patients. That doesn't mean that there's no benefit. And certainly it's reasonable to assume that benefits of vaccination in transplant recipients outweigh the risks. And there's a very good FAQ from the American Society of Transplantation that I link here that has a lot of information about this. And generally they're recommending that we recommend that our post-transplant patients get vaccinated when they have the ability to do so. While we're waiting for more data on vaccine safety and efficacy in these patients, they should get the mRNA vaccines. There's no information quite yet on the other vaccines that are coming down the road from AstraZeneca and Janssen. But ideally, just like in any other vaccine, we want to try to target patients who get vaccinated pre-transplant because we assume they're going to have a better immunogenic response than if we wait till after transplant. There was a question in the chat about whether we should be waiting to vaccinate patients after transplant. And there are going to be patients that may get the first dose and then get transplanted in between. And then there's a question of when they should get the second dose. And we really don't have a lot of good information about this. I think because of the severity of COVID-19, the risks that we assume for our patients, we should not hesitate to get them vaccinated, even if they're not going to have the most ideal response soon after transplant. There's been some talk about whether we should recommend waiting 3 months, 6 months after transplant. And really right now we don't have data to guide people. There will be more data coming, specifically in liver patients. And I also want to point out that the AASLD has convened a vaccine working group. Again, Bilal is part of that. And we're writing a document we expect to be available in the next few weeks, which will have some guidance, but some of these questions are just not answerable right now, and hopefully will be soon. So to summarize, immunosuppression may be protective against severe COVID-19. Liver transplant recipients may not be at increased risk for severe COVID-19 and may have lower mortality rates than the general population. High doses of mycophenolate may be associated with severe COVID-19, while tacrolimus may be associated with with decreased mortality compared to other immunosuppressants. Preemptive reduction in immunosuppression during COVID-19 can be potentially harmful. And in hospitalized patients with COVID-19, consider lowering the overall level of immunosuppression, particularly the anti-metabolite dosages. mRNA vaccine trials have had few participants with liver disease and none who are immunosuppressed. The benefits of vaccination in transplant recipients likely outweigh the risks, and liver transplant recipients should receive the vaccines when available, ideally pre-transplant. Just to close out, I want to thank the AASLD for their support and COVID-19 Clinical Oversight Committee. The members are listed here for their tireless efforts to update our document and to present webinars. This committee has morphed a little bit to start to take on the vaccine issues, but this is the group that's been really doing a lot of the work throughout the pandemic. And if you're interested, our next webinar is on January 28th, 1 to 2 p.m. Pacific time, and it's on vaccination in patients with liver disease. We have some experts on the Moderna and the Pfizer vaccines that will be speaking. The link is there. You can also go to asld.org/COVID-19 to get to our webinar page. It's free to register, even if you're not an AASLD member, and it will be available online afterwards as a recording. I really appreciate your attention. Thank you very much.
Thank you, Oren. Amazing, information and very precise. Before we go to ask some question and answer, I just wanted to announce our app game winner, and which is Sunny Sandhu. Congratulations! Not only that we were able to finish way early, you also got $100. And for other audience, if you keep joining for our next webinar, you will have a chance to get that $100 gift certificate. So Mike, I know that you have a question, and then I have a few questions. Go ahead, Mike. You're muted again.
You haven't heard of this Zoom thing yet, have you?
Dr. Fix, thank you again for your great lecture. And so one of the questions that I had was, what advice are you providing to your liver transplant patients? And for those who are outpatient and contract COVID-19, how have you been managing them if they're good enough not to stay in the hospital, to come into the hospital rather?
Yeah, good. Two good questions. So first of all, as far as what I'm advising patients, you mean as far as the vaccine?
Yes, and then also in terms of staying away or in terms
of sure. So I mean, from the beginning, I've been really trying to drill into my patients the importance of following all the guidance that they're hearing about: masking, washing hands, staying out of crowds. And we know even when they get vaccinated that risk is not going to go to zero, and they need to continue to do that. So I don't think the recommendations are that different from the general population, but I do emphasize to the patients, as you heard from Renu's talk, patients with liver disease are at higher risk for severe COVID-19. They may not necessarily be at higher risk for getting COVID-19, but if they get it, they're at higher risk for dying. This especially goes for our decompensated patients. I agree that our decompensated patients, whether they're waiting for transplant or not, are probably the patients that we want to target for the vaccine as early as possible. And so I'm also starting to to tell my patients the moment you have a chance to get the vaccine, you should. I don't think it's totally clear right now how we're going to be distributing the vaccine to patients with underlying medical conditions. It's probably going to be left to not just the states, but individual hospitals to identify those patients. And so one of the things the AASLD is trying to do is to get our liver patients some priority based on the data that we have. So we may not be able to change the CDC's prioritization schedule, and they've already prioritized patients with liver disease by lumping them in with underlying medical conditions. But maybe we can influence hospitals and states to target patients with decompensated liver disease to get the vaccine as soon as possible over others. As far as what I'm doing with patients who get COVID-19, you know, most of the, just in keeping with the data, most of the patients that I have, mostly post-transplant, but some pre-transplant who have COVID-19 have been relatively asymptomatic, have been able to be managed at home. I had one patient who actually did have symptoms, got diagnosed in the ER, was sent home with a kit, a telemedicine kit, and somebody from my hospital is checking in on him 3 times a day and making sure that he's doing okay. We've had some patients come in, you know, for transplant who, you know, just test positive without any symptoms and get sent home and do fine. We really don't know the risk of proceeding with transplant in that setting, so we haven't been doing it. And fortunately, the patients we've had have been able to wait, but that's not always the case. Bilal and I were talking before the webinar, and this has come up over and over again. What do you do with a patient who has COVID-19, symptomatic or not, who is in urgent need of transplant, acute liver failure, for example? And we don't have a lot of good data on that. We've been recommending 21 days from last symptoms or first positive test, 2 negative tests before proceeding, but that may be overkill, and some patients can't wait that long. We're also seeing patients, particularly immunosuppressed patients who are, and I lump liver disease in immunosuppression, relatively speaking. We're seeing positive COVID tests weeks and weeks out when we know they don't have COVID anymore. We're probably just measuring, you know, non-viable, non-infectious particles. So I think more information needs to come out about how to manage those patients, but we're probably being overly cautious for good reason, and hopefully we'll be able to dial back a little bit soon.
So Oren, one question that we all, who's getting vaccine, a lot of us and have symptoms like fevers and muscle aches, and when our liver patients will be getting these vaccine, what are some, because, you know, we will be getting all these calls, right? So I know that there's not, what literature you have reviewed, is there something which is more common and you can say if this is vaccine related or this is more, especially on our decompensated cirrhotic patients?
Yeah, I agree. This is going to be tough. You know, the most common symptoms are pain, redness, swelling at the injection site, fever, muscle aches. It seems to be more common in younger people, and more common in the second dose than the first dose. Actually, I was joking with one of our nurses because I got the second dose and, you know, I had mild symptoms. I had a little bit of a headache. I had a little bit of shoulder pain for a day or two. It wasn't any worse than the first dose. I was fine. And she was complaining about how she was just terribly sick with fevers for 3 days after the second dose. And I speculate it's just because I'm probably in the old category now, and she's definitely in the young category. I think it's going to be tough, especially with fever, to know what's going on. But I think, you know, these symptoms are usually gone in a day or two. And so I think we can probably hold off and see how patients do without bringing them into the hospital for cultures and things like that. But I think if they have the typical symptoms, you know, for a few days, we're not going to get too worried. Certainly if they have unusual symptoms, you know, we might need to check their liver enzymes. What we don't know right now is there a possibility of mRNA vaccines inducing rejection, for example? There's that theoretical risk, and we just don't have that information. So we're going to have to be cognizant of that.
So one other question that comes in, if you have to give a task from your hospital, that whether it's post-transplant patient or your cirrhotic patient, which one would you choose based on the data which you know and you presented? What would be the group of patient you think is the higher priority in your?
Yeah, I think we have to be careful about this. So I think the data is suggesting that the pre-transplant patient is at higher risk of dying from COVID-19 than the post-transplant patient. Right now, the CDC actually puts patients who are immunosuppressed and post-transplant patients in a higher risk category than patients with liver disease. They say that patients with liver disease might be at higher risk. Patients who are immunosuppressed are at higher risk. That's what the CDC says. They're all lumped into the category of underlying medical conditions, the phase 1C. So I don't want to take away priority from patients post-transplant because we don't really know. The data that's suggesting that these patients are doing okay is mostly retrospective or observational studies. There's no randomized studies, of course. And a lot of it might be just because we're managing these patients really well. You know, maybe we're reducing their immunosuppression when they get sick and protecting them from a worse outcome. So we don't know. And I don't think that we can say that patients that are post-transplant are truly protected from COVID-19 because they're immunosuppressed. So if I had a choice, I would give it to the patient pre-transplant, certainly the decompensated patient first. I'm probably not going to advise, say the CDC or hospitals to not immunize patients post-transplant because I think they're also at risk.
And overall, our vaccination rate in our general cirrhotic population, even if you take hepatitis A and B or other vaccination and shrink risk, is not, we don't do a good job, let's be honest. So how would we do, what we as physicians, as specialists, that we should try to work with our patients to make sure that this is such an important thing that they get the vaccination and have all the education?
Yeah, I mean, I don't know if we're going to do better over the long term with COVID vaccination or not. I think there's a lot of distrust about the speed at which the vaccine was produced. And like I shared with the patient I had from Alaska, there's so much new information coming out and the general public doesn't really know what to make of it. You know, when you hear that it's mutating this rapidly, it's reasonable to think, well, the vaccine that was produced before that mutation was known is just simply not going to work. And we know that's not true. The spike protein that the vaccines are targeting hasn't changed in these different mutations. And so we expect that the vaccine is going to be effective. But I think it's going to be a lot of education. It's got to be part of our discussion with the patient at every visit, which is hard. We've got lots of things to talk about. We got to talk about alcohol. We got to talk about HCC surveillance, and we got to talk about wearing a mask. And now we got to talk about the vaccine and all the different nuances about that. We don't have the time, but we have to try. I also think what's been successful in our program, we have a transplant ID physician who's part of our program. He's employed by our transplant program, and so he's really invested in making sure that our protocols about vaccination are really evidence-based, that everybody's on the same page, and that we make this part of our transplant evaluation. That just like we expect an echo and we expect certain labs, we expect TB testing, we're not going to proceed with transplant unless we have these things in place. We're trying very hard not to proceed with transplant until they've done the vaccines. It's hard. We're not going to withhold transplant from a patient who desperately needs it because they didn't get their third Hep B shot. Of course not. But we need to make it a priority and let patients know that this is important. And yes, they have a choice, but really there's no downside. And waiting until they're post-transplant to vaccinate them, they're not going to respond as well. So it's really important to get them before transplant.
Thank you so much. I know that this is such an evolving field, and whenever we have discussion every week, we have some new data points. Yes. But all of our three speakers, it was a great learning experience. And so I know Julius is not here. He must be sleeping right now, but
I hope so.
Yeah, I hope so. Renu and Oren, thank you so much. And for all the audience who stayed and gave us your evening. And we would love to see all of you next Thursday at the same time for HCC and benign liver lesion. And we're giving back your 15 minutes. So enjoy and take care, everyone. Thank you.
Thank you very much, everyone.